Dear friends, this is our 10th webinar series on update of spine surgery. This will be on spinal deformity complications, and we have three distinguished speakers, and Professor Max Aibi will be moderating. I give the words to Professor Aibi.
Thank you very much. I think this is a very good idea to have a conference about this topic and to look to it from different angles of perspective. So we have neurosurgeons and orthopedic surgeons here, and we are talking about spine surgery, which is increasingly an own specialty. So I would like to invite Richard Assaker from Lille in France to give his first presentation about adult spine deformity correction and its possible complications. So please, Richard.
Thank you, Max. Thanks, Mehmet, for inviting me to such a highly orthopedic topics. So I'm a neurosurgeon, professor of neurosurgery in Lille University, and I owe all what I know today to my friend and master Daniel Chopin, who is ortho deformity surgeon, who taught me for 10 years the basic principles and how to achieve correction of adult spine deformity, degenerative deformity, and how to avoid such complication. So let's, can you see my screen?
Yes.
Yes, okay. So spinal deformity is a highly complex topic where first to get the corrective measures, you need to understand the postural features of your patient. And if you look to this standing EOS films, you can plan your surgery. And the second topic would be how to deal with your surgery with a minimum of complications. So you can see that such a patient needed a major surgery with a VCR and then a closed wedge osteotomy to realign the thoracolumbar area and restore acceptable balance. I would like to start with a typical case that we encounter very frequently. This patient, he's in 2017, asked to be seen by a senior spine surgeon for back pain. At that time, the surgeon says, you need some rehab and you don't need surgery. In 2028, he went back to him and he said, I have severe pain and start having some claudication. And the surgeon decide to do a laminectomy and fusion on this surgeon. The only thing that has been, I would say, underestimated is this patient is a Parkinson patient, and this was the result after laminectomy and L3, L5 fusion. Lots of mistake in this, and this is, I would say, the iatrogenic deformity on this patient who collapsed to the level above. This is called proximal junctional failure, even on the short segment here. And the mistakes were doing a full laminectomy, doing a short fixation with a flat hypolordotic fixation and end up in a disaster. And this is how it looks like. And this is how the patient looks like with the complete bascule of his trunk anteriorly. This patient was he's still an artist. He's a German guy working in Paris. And look how miserable he looks like. So mistakes and iatrogenic deformity is a part of daily life. This is how he was. And this is his paint here. And this is what he drew me to illustrate how bad was his back before the treatment. You imagine this is an illustration of an artist. So I saw him in this situation here, and here are all the what we need to evaluate this deformity and do correction. So this is his CT, MRI. I won't go through details. And I performed traction on dorsal decubitus that showed a fair enough reducibility. And we end up by doing a VCR, placing a cage anterior, and realign this patient. I've done a mistake here by stopping at T10. Daniel Chopin taught me always, do not stop in the Parkinson disease on T8, go always to T4. And I did not forget that. But for once, I thought that maybe with an optimal alignment, I could save the superior. And look what happens is this is 4 days after the surgery. He was truly in a good situation. At 6 days, look what happens. He collapsed the upper instrumented vertebra. He presented PG failure, proximal junctional failure, and Ricard his pain. So I had to go to T4, and now he's fine. What I would like to send as a message is, please, your first surgery has to be well planned and well uh, executed. This is a patient before, and here he is now, almost 3 years after the surgery. You see he looks like a Parkinson, but now he is much more comfortable. So we know roughly that complication in deformity, in adult deformity surgery, is 40% of the case, which is very, very high, and reoperation rate is 26. And all what we're talking about are mainly mechanical complication that could be resumed by proximal junctional failure and kyphosis, distal junctional kyphosis and failure, or hardware failure with a pull out of the screws, rod and screws breakage. Of course, Mehmet knows very well this paper is a review of the literature, is a recent paper that everything is in, and you can see over 26,000 patients with a mean age of 60. We can see the number of complications around 35% and 20% revision surgery. We have all the systemic complication, the neurological complication where Professor Lamartina will talk about the infection. And if you look to the implant failure, all the mechanical failure, it's a high percentage of mechanical failures. Here are the action and the measures to avoid those complications. And we all could go through details in this paper, but we don't have enough time to go point by point, but I will resume it later on. Second paper that I select is a paper from the team of Lamartina and with Pedro Berhano, who also does a similar publication on high percentage of complication and how to avoid that. So if as a neurosurgeon that came late to such a deformity, if I look as an observer, all what we're talking about, all what we're trying to do is getting the optimal alignment to get the less mechanical complication. So alignment and mechanics are linked together. And we've been told that we have to look to the spinopelvic parameters, of course, but the best alignment still has to be defined, the best alignment and the best simulation. So we have many schools, I would say, the Schwab, SVA, pelvic tilt, the mismatch between pelvic incidence and lumbar lordosis has some formula for that, the global tilt, the gap score with the European deformity group. Professor Lamartina is more and more talking about also the sitting position. So it's still evolved, but we need to get a formula that showed us what is the best alignment based on the age, based on the quality of the bone, based on the morbidity of the patient. So this is the basic that the SVA has to be less than 50, the pelvic tilt has to be below 20, and this is relative, and the lumbar lordosis has to match pelvic incidence, and this is well known. What we also focus in our department, and this is also because of Daniel Chopin, is how important is the distribution of the lordosis. Not only getting an SVA, a global alignment that is below 50 millimeter, but also the distribution of the lordosis between L4 and S1 has to be around 70% of the total lumbar lordosis. So, and also Pierre Rousseau insists on how important is low versus long lordosis. In the coronal also, it's important to get the plateau of L4 parallel to S1. Once we get the global balance, the distribution of the lordosis, and these basic things, I think we can get a good alignment according to the pre-op deformity. The gap score also is more and more popular, and also the advantage is that gives you on the extreme pelvic incidence, very small pelvic incidence or very high pelvic incidence. This is seems more adaptable for simulating good alignment. So in our department, we try to through a multidisciplinary consultation have planned the surgery before, planned and simulate the surgery. You know, all the method of simulation. This is ancestral, where we with films, we cut the films and we know the angle of for restoring. Surgimap, everybody knows. Chaos, this is the one that we use for, but all of this, all about this is alignment, is geometrical alignment. We have no aspect of mechanics in this, but we assume that getting the optimal alignment will allows us to optimal mechanical distribution of the stress. So this is my the AKOPS that I use today, and we can see the simulation here. You can see that I bringing back the compensatory mechanism to normal. Here is the pelvic tilt that is switched to the green area on your right. And you can see that my patient virtually is falling down. So we try to simulate the osteotomies. This is a PCO, posterior colon osteotomies, on all the available levels, and you can see that the correction is better but not enough, and we gradually go to get the optimal alignment. And we end up, because this is not enough, by doing a pedicle subtraction osteotomy. You can see here pedicle subtraction osteotomy. We take the lowest one possible, L4, and we assume that we can get till 25, 27 degrees of correction of lordosis. Once we get this menu on how to virtually get back to optimal alignment, we execute the surgery, and we get what we planned for if the surgery is well done. So we won't have time to give you examples, but all this is planned in advance, and those are the post-op X-ray of the patients. So this is the patient before the surgery. Imagine how disabled is walking with the anterior vascular, and this is 1 year after the surgery on the right left. This is here also in a foreign country. They invite me for a minimal invasive work, and you imagine that this could not be minimally invasive corrected. So we've done osteotomy of T4 and T8 S1, and this is how he looks just after the surgery. So very quickly, to avoid PGK, there is many rules to this, and we know that PGK is related to the age, to the surgical approach. Is it open? Is it hybrid? Sorry. Is it open? Is it hybrid? To the rigidity of the construct, going to the sacrum, damaging the posterior element at the upper or at the proximal or the distal junction. So what we do usually is we try to preserve the posterior element at the apical, at the cranial and the caudal part of the instrumentation, do the PSO as low as possible, try to distribute the lordosis, get the optimal balance in one shot, and decide where to stop. Of course, we should not stop on the degenerated level or on the kyphotic region, and we could consider from time to time external immobilization. You can see here that the cranial part and the caudal part of the instrumentation, we did not take the spinous process, and we did not take the supraligamentous complex. Here is a Parkinson patient. In this situation, we use a double rods, and we isolate the site of osteotomy by a short construct, and we bridge it with the long construct above. Also, and especially for my colleague neurosurgeons, it's important to learn how to go to the sacrum. Sacrum with one screw in S1 is suboptimal, and it will leads always to a failure. So we should consider 3-point fixation, S1, LR screws, and ilium to get a nice and reliable caudal fixation. I will stop here because my time is over. I wanted to show you a case where everything were well done and we had lots of complication. Thank you all, and I'll be here for any question.
Thank you, Richard, for this excellent presentation. And I guess there are some questions from the audience.
Yeah, I'm listening if any question.
Any questions? So, nobody? So let me ask something. I mean, at the moment, you know, there is a lot of discussion about this huge surgery in this severely deformed degenerative spines, and specifically in the Parkinson's disease, as you showed very, very well. The discussion is always now, is it really necessary to make such a big surgery, or are there alternatives? And there are people who now say there are alternatives. You can do the most important, resolve the most important clinical problem. Maybe this is the compression of the nerve roots or the spinal canal in this degenerative deformities in the lumbar spine, specifically in the lower lumbar spine. Is it possible to avoid all these problems by doing just endoscopic decompression of the nerve structures without dealing with all these mechanical problems, what you may encounter with? So, I mean, I think it's important to send out here a message how far this is possible, or whether we don't really have data to support that. So what is your opinion, Richard?
I agree 100% with you, Max. This is why I think that the first surgery, if you are able to decompress without any iatrogenic consequence, this is what we should aim for. And I do endoscopic approach, I do minimal invasive tubular approach, and my first objective is not to realign the patient. What I have many examples or how important is to go minimally invasively, decompress the root in a deformed spine, in a highly scoliosis, and patient is complaining actually of radicular pain. The problem is he's complaining of radicular pain. He go to a surgeon who try to realign because he want to address the back pain and to decompress indirectly the nerve, and this is where the problems start to happen. I would never do a deformity correction before making sure that decompression is not um, the issue that we should address. For Parkinson, the neurologists are involved and deep brain stimulation, and usually the neurologists who push for realignment. So I agree 100% with you.
Yeah, I think this is very important, even more important for the future, because we are talking all about in the Western world, but not only in the Western world, also more and more in countries where you would expect more pathologies in younger people. We are basically confronted with the aging society, which is aging rapidly. We know that in Europe in 2050, that means 25 years from now, we have about 400% increase of male patients which are more than 80 years old, and 300% increase of women who are more than 80 years old.
Mhm.
And I can only speak out of my own little experience, personal experience. I mean, I have a brother who has Parkinson. He's 78, and he has indeed a scoliosis. Classical. I mean, everybody would say that's what you have to do. But I mean, his problem is in fact mostly a radicular problem. So finally, I had to go against everything I knew until recently, and just do a decompression, minimal invasive, endoscopically, and he is quite happy. And in fact, I think we have to look at these alternatives because of the costs. I mean, if something goes wrong with this big surgery, these are enormous costs for the society, for the healthcare system. And everybody talks about increasing costs in the healthcare system. And yet we are confronted with this complex pathology where people really want to have a better quality of life. So I think it will be very important in the next years to clearly separate the pathology which may be accessible to endoscopic minimally invasive surgery and pathology which doesn't allow this option. I personally, for me, it's still difficult to really separate. Sometimes you say, okay, we do just the minimum as possible, and then you are punished because then something happens, and which then finally you end up with a long fixation, or you do immediately a long fixation or a correction, and then you are punished again, and then you say, oh, why I did that, why I did not try the other one. So I don't know exactly where to pull this line, but I think this is a very fundamental question.
So, Max, the patient you talked about, who does the endoscopic access?
Oh, there is, for instance, in our country, there is very poor endoscopic surgery.
But
In
not
fact,
you, not you.
I'm not doing that. I
Yeah.
mean,
So
after 50 years
this
of
is the problem.
it's.
Yeah, this is a problem. I think the problem is to have a spine surgeon who had a culture or all what we can do. This is why I learned to do endoscopic surgery also. I do endoscopic. I have been doing tubular access since, for a synovial cyst, for instance. I never fuse my synovial cyst from the first surgery. I go endoscopically. I'm sure that I'm not iatrogenically destabilizing the segment. And this is why, this is very good example, synovial cyst that you can decompress without needing to fusion. And I agree with you. Sometimes Parkinson comes to you with one root compressed and we realign two. The problem is we need a surgeon that does everything in the spine. But today we have the big deformity surgeons that revise all what is done before, and the endoscopic surgeons that push the limit, and they have no education on deformity. They only know. So if you have a friend who knows how to do the endoscopic surgery and you direct the goal of the surgery, that's fine. But I think this is the issue. We have to train our young generation to be able to detect and to execute something that could be done minimally invasively.
Yeah, I agree. You know, and what we try. I mean, I'm now at the end of my career, but in our department, we try now to have people, at least 1 to 2 people, who do finally nothing else than endoscopic surgery, but they are part of a team where we
Yeah,
discuss the cases, and then we say, okay, that's probably the
exactly,
best solution for the
exactly,
moment.
exactly, exactly.
So, any other comments, maybe from the audience or from the faculty?
Max, may I have a small comment about this point?
Yes, please.
Very shortly. Excluding a Parkinson patient, we try to define the symptomatic level in case of adult scoliosis. Based on this, we proposed many years ago, several years ago, sorry, a classification. We try to define when it's possible to perform a very selective surgery when the symptomatic level is far from the apex of the curve, or differently, more expanded surgery when the symptomatic level is in the apex of the curve. Different is if you have a very unstable, a very coronal or sagittal malalignment. In this case, we identify how many the cutoff. The cutoff in our experience is a lack of lordosis more than 25 degrees.
Yes, I think this is of course something we will have more and more to respect, that there are systems of classification at least which gives you a frame in which you can move. But I think what Richard said is very important, you know, is that you have people in the team who really know the consequences, and also the technical way how you solve major deformities in the lumbar spine, which reflect also in the thoracic spine, and you know, to basically be on the side of those who can this technique of endoscopic surgery. I think if you want to be successful in the endoscopic surgery, which is driven by technology today, by massive change of technology. I mean, we talk about endoscopic surgery since 25 years, but it has not really taken off. Maybe since 2-3 years, there is technology available which make procedures possible which were not possible until now. So I think it is very important to talk in an interdisciplinary team, you know, and so the question is no longer whether you are a neurosurgeon or orthopedic surgeon, whether you are a spine surgeon who really understands the problem of the spine in terms of biomechanics, in terms of dynamics, in terms of muscular strength, and so on and so on. So I think this is, when we talk to younger colleagues, I think we have to tell them again and again that they have to solve this contradictions in the daily practice what we have. And I think it has been shown very well by Richard, specifically the first case, what that means. In the first case you can even discuss why this guy did this stabilization, and whether the stabilization was finally the cause of all the secondary problems and not the decompression.
Exactly.
So, we can discuss for a long time about this, you know.
Yes. This patient should had a minimal invasive decompression. A few weeks ago, I saw a patient from abroad who came for deformity plus lumbar stenosis. 2 years ago, I saw him here in Lille, and his main complaint was claudication. I decompress the canal with no deformity correction, and 2 years later, I saw him last week in the clinics. Actually, his posture changes because he's not on pain anymore, so he has not the same deformity than before. He's still somehow having some deformity, but very acceptable. So we have to make sure that we're not also alignment is I saw a patient with acute this lumbar disc, and patients are bent anteriorly, and some surgeon would think that he had a postural problem while he's bending anterior because he's on pain.
Yes, it's you know, I think we believe that all these degenerative spines, the lumbar spines, which are severely degenerated in the aging population, that they have no longer a dynamic. Yes, they have still a dynamic. So that means if you start to stabilize everything in the spine, then you take away this limited dynamics, but it adds on per segment and segment. I have several patients where I tried just to do a minimal decompression, and they function pretty well, you know, and I don't know what would happen when we have stabilized him. But anyway, there was a question I just realized from a colleague. Mehmet, can you see who was asking a question? I cannot see it here from here. So
Yeah, we have one question from Murodjon, who asked, how do you prepare patients for surgery with Parkinson's disease? Should I answer, or?
yes, maybe you can answer, or also
yeah, I would go quickly. For Parkinson's disease, first of all, I will check with his neurologist that his Parkinson is well treated and there is no indication for deep brain stimulation, and et cetera, et cetera. Then mainly he has to understand that this is a major surgery, lots of complication, and does it worth it? And from his side, is he ready to go for surgery with risk of complication? And finally, I don't know what Max, Lamartina, Mehmet thinks, but finally we have to do in one shot if alignment is the issue. I'm not talking about somebody who's complaining of radicular pain. We have to do a global alignment and not stop in the middle of the, and optimal alignment is important. So, and have a good team for rehabilitation after surgery. I know one Parkinson that was unable to stand up. The alignment was good, was unable to stand up for 3 months. She fall down posteriorly, so she had to go gradually, and now she get better. But it's a major surgery, and as Max says, if we can avoid such a major surgery on such a fragile patients by doing a focal decompression, it would be much better.
Yes, thank you. There is also a question from SP, I don't know, and he or she asks, what's the name of the simulation software? I think you showed it. Maybe you can say it again.
It's the KEOPS.
Yes, the KEOPS.
The KEOPS that is distributed by Philippe Roussouly. I think it's called now, the company, it's called just type on Google KEOPS, you will find it.
Yeah. Okay, there are some other questions, if I may. Why did you say that you should not end the construct at T8 in a Parkinson's patient? Can you address that?
Yeah, we don't know why those patients fail, but we know that a part of the risk of PGK is the muscle quality above the fusion. And we know in Parkinson, people, the Parkinson by definition had a tonus problem, had so an asymmetrical muscle tonus distribution between left and right. And we just know that the risk of PGK or PGF on Parkinson people, when you stop, even if the alignment is good, is very high. And we have many examples, and some like Daniel Chopin, like Pierre Roussouly. If you're facing a Parkinson and you have to go to an alignment, you have to stop at T4 or T3. Do you agree, Max, do you
Yes,
agree?
I agree completely. I have done quite a few Parkinson deformities, and I made the same experience at the beginning, always, to avoid too long fixations, but there is no doubt you have to go to at least to T4 to make sure that you will not end up in a zone where you have this asymmetry of the muscle tonus, they fail. It is no question. It's also in the literature very well documented. I agree with that. So there is still a question, but then I think we should go on. Oh, that's the same as before.
Yes, the same, yes.
Yes.
Same. T2 or T4 is the same.
Yes. So if there is no